angiotensin receptor blocker and neprilysin inhibitors in heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So what the new pathway we have for a national consensus. What we are going to discuss is a 15-point consensus. What we know is heart failure can be deadlier than many cancers with 5-year death rate that is comparable to various common malignancy like leukemia, colorectal carcinoma, non-Hodgkin's lymphoma, and breast cancer. So the 5-year death rate is compared to various common malignancy. Now also what we should know that heart failure is a progressive condition with a very high mortality. Now, in between chronic disease progression, there are multiple acute exacerbations, which leads to overall high morbidity as well as high mortality in these patients. So heart failure patients, as we know, they are at very high risk of death and hospitalization. 9 out of 10 patients are mostly symptomatic, even with current therapies. Nearly 1/3 of the patients are at high risk of hospitalization or cardiovascular death, including those patients who appear stable. Each episode of heart failure increases the risk of mortality further, which reduces the mean survival. Like as the disease progresses, there are multiple episodes of exacerbation, which leads to increased mortality and untimely death. So globally, the mean age of these patients outside India is 73 years, with in-hospital mortality of 3.8% and post-discharge mortality of 8.6%. For Indian patients, the mean age is 53 years with in-hospital mortality 30.8% and post-discharge mortality of 26.3%. Now, patients with heart failure in India, they are affected at younger age. They have a high mortality both in hospital as well as after discharge. As per inter-CHF study, 23% of Indian patients with heart failure, they die within 1 year, of diagnosis. So, in Indian African patients, they are at the youngest cohort with a very high mortality. And in the analysis of cause-specific mortality, we noted that cardiac death alone in patients of India, where these patients were at a highest hazard of cardiac death. And I have informed that survival rate in these heart failure patients, it is worse even more than that of known cancers. The prevalence of heart failure is about 8 to 10 million patients in India, which constitutes about 1% of adult population. Indians, they have a post-admission mortality of 20 to 30%. In Indians, the medication adherence, it ranges from 25 to 50%. Indians, they have a relatively young population of heart failure. The incidence of diabetes in heart failure in Trivandrum Heart Failure Registry was 54.9%, and the incidence of hypertension in heart failure is 42%. Now, if we further analyze the Trivandrum Heart Failure Registry, the key points are 3 out of every 5 patients, they have died during 5 years of follow-up, with a median survival of approximately 3 years in this young cohort of heart failure patients. Lack of goal-directed medical therapy or in patients with heart failure with reduced ejection fraction and frequent readmissions were associated with a high 5-year mortality. Only 25% of patients, please go back. Only 1/4 of the patients were discharged from the index hospitalization on guideline-directed medical therapy, and importantly, prescription of guideline-directed medical therapy at discharge were associated with a lower 5-year mortality rates in patients with heart failure with reduced ejection fraction. Interventions aimed at increasing guideline-directed medical therapy may improve heart failure outcomes in India. So these are the goals. First is to increase the survival to both sudden cardiac death as well as progressive heart failure. We have to reduce the morbidity, that is, we have to reduce recurrent reduce recurrent hospital admissions. That is, apart from being very unpleasant for patient, it is also very costly and distressing. It is like a bad prognostic development. And lastly, we have to make the people feel better also. We have to improve the quality of life also. We have to allow the people to continue to lead normal and unrestricted life as possible. So these are the landmark drugs and device trials in heart failure with reduced ejection fraction. From initial valsartan heart failure trial to consensus to SOLT-T. So in various stages, we have added new drugs in the armamentarium for the treatment of heart failure. And lastly, recent trials we have, which suggested the role of this neprilysin inhibitors. So these are all those landmark trials which have made us to add newer drugs in the armamentarium for heart failure. The drugs we have, which starts from like valsartan heart failure trial to recently added DAPA heart failure to paradigm heart failure. These are the landmark trials which have shown the pathway for addition of uh, uh, these newer drugs like gliflogins, dapagliflozins, and these uh, uh, SIDMAs, the drug we have what they have searched from these newer trials. And lastly, the big step forward was, so this was the landmark trial which have shown the pathway for the addition of ARNIs in patients with reduced heart failure, and that was paradigm heart failure study design, which shows the non-inferiority as well as superiority of this ARNIs in a patient with reduced heart failure with ejection fraction. So this was some like key criteria of inclusion. These were the patients with NYHA 3, 4, with those patients were on stable patients were on treatment with ACE inhibitors or ARBs, and like these patients without any history of angioedema, without hypertension, and they were on ACE inhibitors or ARBs. And this was the trial it was geographically diverse, most racially diverse. It was the trial with largest mortality and morbidity trials in these patients. This was the trial of paradigm heart failure. So this was the outcome of the trial in which enalapril was compared with ARNIs head to head, and which have shown that there was about minimum 20% reduction in overall cardiovascular death, heart failure hospitalization, overall mortality, sudden cardiac death with ARNI groups. So these are the like guideline directed medical therapy like ACE inhibitors, beta blockers, aldosterone antagonist, hydralazine, and uh, like when we there was when these all these drugs have definitely demonstrated about 30 to 40% relative risk reduction in heart failure hospitalization. But if we'll go for ARNIs, it is like top of this above drugs with about 20% risk reduction in mortality when they were compared with these drugs. So when we start these drugs, not only it decreases the mortality, the functional class improve from NYHA 3-4 to NYHA 2 once we start this drug. So across all subgroups, across all age, across all ejection fraction, GFR, blood pressure, anti-proBNP levels, this ARNIs is superior to ACE inhibitors across all the subgroups of chronic heart failure with reduced ejection fraction patients. So as when we go through paradigm heart failure trial, this clinical efficacy was beneficial clinical beneficial effects was seen in Asian subgroups. 20% of the stable patients. Actually, what is the illusion of stability in heart failure? About 20% of stable patients, that is those patients who had no prior hospitalization in paradigm heart failure trials, they had a primary event. And 17% during the course of the trials, they died. Of stable patients, so-called stable patients who experienced their primary event, death preceded heart failure hospitalization in 51%. And 60% of these deaths were sudden cardiac death. So what we can conclude is ARNI should be started as early as possible without waiting for deterioration to occur. So as per the recent guidelines like 2002 HACCH, in patient with heart failure with reduced ejection fraction and NYHA class 2 to 3 symptoms, the use of ARNIs is recommended to reduce mortality and morbidity. And in patients with previous or current symptoms of chronic heart failure with reduced ejection fraction, the use of ACE inhibitor is beneficial to reduce morbidity and morbidity only when the use of ARNIs is not feasible. And lastly, in patient with previous or current symptoms of chronic heart failure with reduced ejection fraction who are intolerant to ACE inhibitors because of cough or angioedema, and when the use of ARNIs is not feasible, then only the use of ARB is recommended to reduce mortality and morbidity. So what we can conclude is when ARNIs use is not feasible, then only we should use ACE inhibitors or ARBs. Now the next question is acute decompensated heart failure different from de novo heart failure? So de novo heart failure is a distinctive phenotype from acute decompensation in chronic heart failure. Acute decompensated chronic heart failure is like older population, worse baseline status and lab findings. They have known history of underlying heart failure. Whereas de novo heart failure, these are the patients, they don't have any previous history of heart failure. The acute decompensated chronic heart failure means they are already having ischemic heart disease, COPD, AF, diabetes, or stroke, or history of CABG and PCI are more frequent. Whereas de novo heart failure, like these patients, they don't have such history. In such cases, trigger event is like poor compliance of medication, resistance of medication, infection, excessive water or salt intake, cardiovascular complications, surgeries, alcohol, digitalis. Whereas in case of de novo heart failure, cardiac ischemia or valvular incompetence, like sudden acute MI, acute MR, sudden viral myocarditis, or toxic insults, they produce de novo heart failure. So the clinical presentation is sudden onset cardiogenic shock or acute pulmonary edema, whereas acute decompensation involves dyspnea, orthopnea, lower limbs edema, ascites, weight gain. Here, the main pathophysiology is pulmonary and systemic vascular congestion caused by LV dysfunction. And there is a maladaptive neurohormonal activation, which leads to fluid overload and redistribution. In case of de novo heart failure, there is an acute hemorrhagic dearrangement caused by LV systolic dysfunction. Acute hemodynamic derangement caused by acute LV dysfunction. So the newer strategy of inpatient initiation with ARNIs, it was guided by Pioneer Heart Failure, and the study design, those patients who are stabilized while they are still in hospital. In these patients, we have either given sacubitril, valsartan, or enalapril, and you just at the when they are admitted in the hospital, at that stage we have compared these two drugs, and we did blinded study treatment for 8 weeks. So even in when we start early among inpatient patients in who are having heart failure with reduced ejection fraction, who are hospitalized with acute decompensated heart failure, the in-hospital initiation of sacubitril valsartan, it leads to decrease in NT-proBNP and it leads to improved clinical outcome compared to enalapril. So what we see is there is reduced cardiovascular death or hospitalization for heart failure in sacubitril valsartan group as compared to the enalapril, and biochemically it was seen as a reduced in NT-proBNP levels. So even when we do a subgroup analysis in these de novo heart failure patients, what we can see, there is with sacubitril valsartan, there is definitely it is beneficial for, as compared to the enalapril. Next slide. So what we can conclude is such improvement in early clinical outcome would be lost in a scenario of ACE inhibitor ARB speed treatment. That is ACC 2021 ECDP writing committee. So the outcome in patients without a prior ACE inhibitor ARB exposure, in sacubitril valsartan, they have definitely, this group is associated with reduced cardiovascular death, hospitalization, changes in anti-proBNP. These patients, they have definitely early clinical benefits as compared to the ACE inhibitor ARB groups. So 43% in the proportion of overall patients who were de novo heart failure, with rates ranging from 20% in Northern America to 79% South Asia. In prevent study, 66% of these patients were newly diagnosed heart failure with reduced ejection fraction. So even in this group of patient, the sacubitril valsartan keep this patient out of hospital, and they help them live longer. So these patients, they have definitely significantly lower incidence of composite of cardiovascular death or heart failure rehospitalization in these de novo hospitalized heart failure with reduced ejection fraction with sacubitril valsartan. So this was the study paper in which this was transition study, in which there was initiation of sacubitril valsartan shortly after hospitalization for acutely decompensated heart failure in patients with newly diagnosed heart failure, and there they have started this sacubitril valsartan early in these group of patients. So it improves echocardiographic parameters in de novo hospitalized heart failure with reduced ejection fraction. There are changes in echocardiographic para-reversal of remodeling. Sacubitril valsartan improve cardiac remodeling and pump functions more effectively compared to ACE inhibitors ARB in de novo hospitalized heart failure with reduced ejection fraction patients. It also reduced TROP-T concentration in de novo hospitalized heart failure ejection fraction. There is significant reduced TROP-T concentration with sacubitril valsartan in de novo hospitalized heart failure with reduced ejection fraction patients. So a more de novo than prior heart failure with reduced ejection fraction patient achieved target dose at week 10, and fewer had leak compliance related issue, and fewer have side effect and permanent treatment discontinuation. So this is the what we can conclude from transition studies, like early intervention with sacubitril valsartan should be considered to delay disease progression in patients with de novo heart failure with reduced ejection fraction. First line initiation of sacubitril valsartan in de novo heart failure with reduced ejection fraction alongside the initiation of other guideline directed therapies is feasible and is associated with better risk benefit profile than in patients with prior heart failure with reduced ejection fraction. So 2021 update to the 2017 ACC expert consensus decision pathway for optimization of heart failure treatment. So this is the usual treatment algorithm that which shows that ARNI is preferred choice as a foundational therapy along with beta blockers and diuretics. And because of newer evidence, ARNI is now also recommended in newly diagnosed ACB, ACE inhibitors, ARB naive patient. Like until unless it is contraindicated in almost across all class of heart failure with reduced ejection fraction, these ARNIs is the preferred drug of choice. Now, the main aim of clinician, it should be to achieve optimal guideline-directed medical therapy within 3 to 6 months of an initial diagnosis of heart failure. So, what we can conclude is ARNIs may be considered as a first-line therapy instead of ACE inhibitors in heart failure with reduced ejection fraction. If the patient is taking an equivalent of greater than 10 mg of enalapril, or like it is greater than 160 mg of valsartan, what we can do is we can start at 50 mg BD. And if the patient is taking less than 10 mg of enalapril or about less than 160 mg of valsartan, what we can do is we can start at 25 BD of these ARNIs. In 2 weeks, we should assess tolerability, and if possible, we should increase dose stepwise to the target of about 100 BD. The main target should be the 100 BD. Meanwhile, we should measure blood pressure, electrolytes, renal function after initiation and during titration. Now, second is in case when we cannot give ARNIs, we should start initial dose of ACE inhibitors and ARBs, and we should titrate every 2 weeks to achieve the maximum titrated dose so that we can get the maximum benefit. And for beta blockers, similarly, we should start at a lower dose, and we should titrate the dose every 2 weeks until we achieve a maximum dose, monitoring heart rate, blood pressure, as well as sign of decompensation. Sometimes beta blockers may precipitate decompensation of heart failure. Now, what are the reason for failure to tolerate sacubitril valsartan? And second is preventing patients reaching target dose. So there are various symptoms. There are various causes like hypotension, sometimes gastrointestinal symptoms, sometimes hyperkalemia, sometimes decreased GFR. These are the common causes why we fail to achieve the target dose, and these are the causes for intolerance of like sacubitril valsartan. One should know that the irrespective of the dose we are giving, almost across all the dose we have seen the benefits. So participants taking lower than target dose, they had a lower risk of primary event compared to those patients, those who are taking lower than target dose of enalapril. So this we can conclude. So even if we are starting at a lower dose and we are not able to titrate to higher dose, even it is beneficial rather than taking ACE inhibitors. So even in those patients of heart failure with reduced ejection fraction with low BP, these ARNIs, it reduces the risk of cardiovascular death and heart failure hospitalization. It is almost 12% reduction in risk of cardiovascular death or heart failure hospitalization in these patients with low BP. Even in these patients with low BP with heart failure, there is a 12% reduction in risk of cardiovascular death. Now, now a short discussion on ARNIs and risk of hypertension. Now, even if sometimes it may precipitate hypertension, but it is not. It does not lessen the treatment advantage of sacubitril valsartan over enalapril. And older patients with low BP, it requires more intense monitoring. So we should correct volume depletion. We should correct salt depletion. We should start at the lower dose. In hyperbolic patient, the dose of diuretic should be down titrate. In fragile elderly patients with low BP, we should start at the lower dose and we should slowly up titrate. In patient previously on low dose ACE inhibitors ARB, or they are named to ACE inhibitors ARBs, we should start at a very low dose and slowly we should up titrate. As with other disease modifying treatments that have effect on lower BPs, we should start low, go slow, and it should be the standard consideration in clinical practice, particularly those patients who are prone to hypertension. And as like any other drug, maximal dose of sacubitril valsartan may not always be tolerated by every patient. Now, the question is, will introduction of ARNIs reduce the need of device therapy in heart failure with reduced ejection fraction? We know an ICD is recommended for secondary prevention to reduce the risk of sudden cardiac death, as well as all-cause mortality in patients who have recovered from a VTVF causing hemodynamic instability and who are expected to survive at least greater than 1 year with good functional class. And for primary prevention, ICD is recommended to reduce the risk of sudden cardiac death and all-cause mortality in patients with symptomatic heart failure and LVF less than 35% and greater than 3 months of optimum medical therapy, provided they are expected to survive substantially longer than more than 1 year with good functional status, and they have ischemic heart disease that is greater than 40 days post MI or DCMP. So symptomatic heart failure with reduced ejection fraction, we should treat all reversible causes. We should start optimal medical therapy. We should start on ARNIs, and if the patient is still symptomatic greater than NYHA 2, 3, and having greater than with wide QRS, LBBB like between 120 to 50 or like greater than 150, then they are definitely they are candidate for CRTDs. Now, but the thing is, we have gap in evidence. That is, we have like long-term benefits of ARNIs. We don't have much data. And the second is, if the patient is not a candidate for CRT, and the patient is symptomatic with less than 35 EF, particularly ischemic cardiopathy with a history of VTVF, then they are definitely a candidate for ICD. So here again we go to the Trivandrum heart failure registry, where 55% of patients hospitalized for heart failure, they had diabetes. So in chronic heart failure patients, the prevalence of diabetes in and around is about 30%. And in diabetic patient, the prevalence of heart failure is approximately between 10 to 30%. This is from the various major registries and major trials. This is the data we have. So ARNIs, it reduces the cardiovascular death and heart failure hospitalization. It improves quality of life irrespective of the glycemic status. So that they have associated with about 20% reduction in cardiovascular death and about 20% reduction in heart failure hospitalization irrespective of glycemic status. So what is the effect of ARNIs on glycemic control? So these drug is definitely associated with better glycemic control as compared to the enalapril group. With these, what is the effect of ARNIs on insulin initiation and like oral anti-diabetic group? So what we have seen, this new use of insulin was 29% lower with ARNIs versus enalapril, and there were fewer patients. They were started an OHA therapy with ARNIs. So here again we go to the Trivandrum heart failure registry, where 55% of patients hospitalized for heart failure, they had diabetes. So in chronic heart failure patients, the prevalence of diabetes in and around is about 30%. And in diabetic patient, the prevalence of heart failure is approximately between 10 to 30%. This is from the various major registries and major trials. This is the data we have. So ARNIs, it reduces the cardiovascular death and heart failure hospitalization. It improves quality of life irrespective of the glycemic status. So that they have associated with about 20% reduction in cardiovascular death and about 20% reduction in heart failure hospitalization irrespective of glycemic status. So what is the effect of ARNIs on glycemic control? So these drug is definitely associated with better glycemic control as compared to the enalapril group. With these, what is the effect of ARNIs on insulin initiation and like oral anti-diabetic group? So what we have seen, this new use of insulin was 29% lower with ARNIs versus enalapril, and there were fewer patients. They were started an OHA therapy with ARNIs. So, as per the recent guidelines, that what they have recommended is patients of heart failure with preserved EF. Class 1 recommendation is like diuretic, then SGLTs, uh, and those patients with actually I'm unable to see. So now the guideline, as per the guideline, the question is whether those patients with preserved ejection fraction we can start this drug. So whereas for this patient we can give diuretics, we can give dapagliflozins, the SGLT2 inhibitors. Now the use of ARNIs for heart failure with preserved ejection fraction, it is 2B indication. The common side effect of sacubitril valsartan is angioedema, hypotension, impairment of renal function, hyperkalemia, and cough. These are the common adverse effects of sacubitril valsartan. The risk of hyperkalemia associated with the use of a mineralocorticoid receptor antagonist was lower among those treated with ARNIs than those treated with enalapril. And use of ARNIs preference to ACE inhibitors may enhance the ability to use mineralocorticoid receptor antagonists safely, allowing patients to reap the incremental benefits of less additional risks. These are the contraindications for sacubitril valsartan. Like within 36 hours of ACE inhibitor use, we shouldn't use. History of angioedema with or without ACE inhibitors or ARB, pregnancy, lactation, severe hepatic impairment, concomitant aliskiren use in patient with diabetes, known hypersensitivity to either ARBs or ARNIs. Caution is renal impairment, hepatic impairment, renal artery stenosis, systolic BP less than 100, volume depletion. These are the cautions. Drug interaction is with ACE inhibitors. It is contraindicated because of the risk of serious angioedema. Aliskiren, potassium sparing diuretics, because it may lead to hyperkalemia. The NSAID, it may increase the risk of renal impairment. Lithium, increase the risk of lithium toxicity. Birth control pills containing drospirenone. So what we can do is strict low potassium diet we should give. Small dose of loop diuretic we can give. In emergency situation, we can give potassium binders with SLA nebulization. The old is gold glucose insulin infusion in stubborn cases. PET tumor will be a boon. So once we do ARNI withdrawal in patients with heart failure with reduced ejection fraction, it is associated with increased all-cause mortality. Patient who continued with this SVIP sacubitril valsartan combination, if they presented an improvement in functional class, LVF, and decrease in anti-proBNP levels. So it is definitely associated with increased mortality. Now, heart failure, like the heart failure with reduced ejection fraction, like it may become heart failure with preserved ejection fraction. Like they changes from one term to another within a few months to few years. They changes from reduced ejection fraction to moderate ejection fraction to preserved ejection fraction. They changes from one stage to next stage. So improved LVF is used to refer to those with previous heart failure with reduced ejection fraction now who are having LVF greater than 40%. Now in patients with heart failure with improved ejection fraction after treatment, guideline directed medical therapy should be continued to prevent relapse of heart failure and LV dysfunction even in the patient who may become asymptomatic. So even after improvement of ejection fraction, we should continue the guideline directed medical therapy. So these are the pearls of consensus. ARNI is molecule of the century and it is indispensable and superior to ACE inhibitors in reducing cardiovascular death, heart failure death, sudden cardiac death in patient with heart failure with reduced ejection fraction. ARNI also improves LVF in heart failure with reduced ejection fraction, and it reverses the adverse LV remodeling and it improves quality of life in both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. ANI should be initiated as early as possible in patients with acute decompensated heart failure, also in de novo heart failure. Here, time is life years. ANI should be given for at least 3 to 6 months along with other foundational therapy for heart failure with reduced ejection fraction, and LVEF reassessed with echo and MRI before the patient is considered for ICD CRP. ANI should be used in all patients with heart failure with preserved ejection fraction up to LVEF 57 to 60%, along with SGLT2 inhibitor to improve quality of life index and recurrent heart failure. Thank you very much.